First, I want to thank the organizers for inviting me to this very magnificent conference. It's very nice to be in St. Petersburg. It's a beautiful city. And my topic is carotid stenosis as a predictor of cardiovascular risk. I'm a stroke neurologist from Helsinki University Central Hospital. I will concentrate on carotid stenosis caused by atherosclerosis, not other types of stenosis like restenosis or radiation injury. Carotid bifurcation is the predilection site for atherosclerosis and is very often present when a person has risk factors for atherosclerosis. And they are very common. In most Western countries, half of middle-aged men have carotid plaques and 1/3 of women. However, hemodynamically significant stenosis is much more rare. It's reported to be present in 1 to 5% of middle-aged population. And it is well established that carotid stenosis is an important cause of ischemic stroke. About 10% of all ischemic strokes are caused by carotid stenosis. Usually the most common mechanism is thromboembolism from an unstable plaque, which means that it's ulcerated or ruptured usually. But in rarer circumstances, there is hyperperfusion or occlusion of carotid artery behind. And this causes, of course, ischemia to anterior or middle cerebral artery territories or to retina. The typical symptoms are probably common to you all. So sensomotor hemiparesis, dysphagia, neglect, visual field defects, amaurosis fugax, and monoocular blindness due to retinal artery infarct. What is very characteristic for carotid stenosis is that most of patients have prodromal transient ischemic attacks, and about 50% of patients report such attacks, and many patients report dozens or even hundreds of such. Another very typical feature of carotid disease is a high risk of recurrent stroke. This is data from Oxford Vascular Study, but other studies report very similar kind of figures. In Oxford, patient that had a TIA or stroke as a presenting symptom and they were found to have 50% carotid stenosis, had almost 30% risk of recurrent stroke in 3 months. It's a very high figure. And it's much higher than in other stroke subtypes. I don't know if you see this figure and these numbers here, but this can be seen in these survival curves. This is the lowest curve is for patients with carotid stenosis. And this is the proportion of patients that stay, that don't get any recurrent stroke, and it's much lower in carotid stenosis than in other types. From large carotid endarterectomy studies, it is known that certain clinical features associate with high risk of recurrent stroke. For example, male gender, age, diabetes, previous myocardial infarction, peripheral vascular disease, hypertension, and some radiological findings such as irregular or ulcerated plaque in a DSA angiography. Also, when the degree of stenosis, also the risk gets higher. Also, the presenting symptom is important, so that patients with major stroke have 2.5-fold higher risk than patients with ocular symptoms. On the basis of this, on NASCET and EXT, these largest carotid endarterectomy trials, also a carotid stenosis risk prediction tool has been developed by Peter Rodwell and colleagues, and it's based on these clinical and radiological findings. And it's available as an online tool where you can calculate an individual risk for a patient, and also by these simplified pocket guides that you can use bedside. But it has to be kept in mind that, in fact, most of carotid stenosis stay asymptomatic. And it is much more problematic to try to predict what is the risk for an asymptomatic stenosis. And this is especially problematic nowadays when vascular imaging is becoming more and more common. So we find these patients much more often when in their asymptomatic phase. Another thing that makes it complicated is that there is data that in fact the risk of stroke for asymptomatic stenosis is getting lower all the time, so that when it was predicted to be about 2.5% per year during the times when ACAS and AXT were made in 90s, the nowadays figure from Oxford Vascular Study is 0.3. So this makes it very complicated, for example, to predict what would be the results for carotid end arterectomy trials nowadays. But however, we know that some patients get stroke, and we would desperately need more tools to predict who are those high-risk patients. Oh, sorry. Okay, so there is data from studies on carotid and coronary plaques that certain features associate with unstable plaques that have caused symptom. For example, these plaques have large lipid cores, many inflammatory cells, thin fibrous gap, interplaque hemorrhages, ulcerations, and intraluminal thrombosis. And this has resulted in hopes that perhaps nowadays modern vascular imaging could be used to detect these features and add them to these classical clinical features of patients to help risk prediction. And there is data for this, for example, by carotid ultrasound. There is data that plaque area, plaque heterogeneity, and low grayscale median are associated with higher risk. And by transcranial Doppler, you can detect microembolic signals. There is a large meta-analysis by Gupta and colleagues on MRI studies that show that it's a very powerful tool to detect these unstable features. For example, thin fibrous gap, intraplaque hemorrhage, and necrotic lipid core with quite high hazard ratios. There is also hope for biomarkers, but perhaps these studies are still lagging behind. And we would still need some prospective clinical studies to really show us which of these features would be most useful before we can, and if they really help us in prediction before we take them to clinical practice. So due to time reasons, I just briefly discuss other cardiovascular endpoints. There is a lot of data in favor that carotid stenosis also predicts the risk of other cardiovascular diseases, especially myocardial infarction. From NASCET and X, we know that the risk of myocardial infarction for carotid stenosis patients is very high, over 20% in the next 10 years. And therefore, all of these carotid stenosis patients belong to the high risk group of most cardiovascular treatment guidelines, and their risk factors should be evaluated and treated accordingly. And the risk is even higher even 50% within the next 10 years if there are certain features. The risk gets higher when the degree of stenosis is increased, and also patients with diabetes or bilateral stenosis have higher risk. However, we don't really know how to treat, how we should approach these patients. There is suggestions that perhaps at least some group of these patients should be sent to more invasive investigations, and their asymptomatic coronary disease should be treated, but this needs further investigation. So then briefly, what is the current European guidelines for treatment of carotid stenosis? This is European Stroke Organization guidelines for all, both asymptomatic and symptomatic carotid stenosis, and best medical treatment. All should get permanent antithrombotic treatment. This is mainly because of their overall atherosclerotic disease and risk of myocardial infarction. All should get aspirin, and a symptomatic patient aspirin plus dibutramol or clopidogrel. Probably all should be put to statin treatment, and their LDL cholesterol target is below 1.8 millimoles per liter, or at least there should be 50% reduction. Blood pressure should be treated to guidelines, but caution is advised with very old patients and patients with tight or bilateral stenosis or evidence for hypoperfusion infarct. And lifestyle changes have been proven to be very important in the stabilization of atherosclerotic plaques also. Then to the carotid end arterectomy guidelines. These are probably you are even more familiar with than me. So ASO guidelines, there is high evidence for carotid end arterectomy in previous or symptomatic carotid stenosis of over 70% up to 6 months, and the operation should be done as quickly as possible, and Pirkka Vikatmaa will go more deep into this later. But the perioperative risk should be less than 6%, and there are subgroups that especially benefit and subgroups that have a slightly higher perioperative risk but still benefit. And then patients with symptomatic over 50% stenosis, there is data that surgery is beneficial for at least selected patients, especially men with high load of risk factors and recent hemispheric symptom. But the risk of the center should be lower than 3%. For asymptomatic patients, probably there are groups that benefit, but this risk calculation has to be done individually. And once again, groups that probably benefit are younger patients, men, patients that have a high load of risk factors, tight stenosis, and their expected lifespan is over 5 years. So as a conclusion, symptomatic carotid stenosis need to be recognized urgently within 24 hours because of the high risk of recurrent stroke. And there is data that early treatment decreases the risk even by 80%. And rapid carotid end arterectomy should be considered for all with symptomatic stenosis over 50%. And all carotid stenosis patients are at high risk of vascular events, and they should be evaluated for all risk factors and studied antithrombotic medication and statin treatment. And in the future, hopefully, we have better tools to predict who are those high-risk patients so that we could go on to primary prevention. Okay, thank you.
how much carotid endarterectomy performed in Finland per year, and what is the percent of endovascular standing from all? Я задаю этот вопрос, потому что мы близки к Финляндии, у нас очень высокий уровень атеросклероза. We have the same level of atherosclerosis, and St. Petersburg is about 5 million, and Finland about 5 million. How much carotid endarterectomy per year in Finland perform?
You can perhaps tell more about Finland. I know the situation for Helsinki, that we do about 250 carotid endarterectomy per year. I don't think we do a lot of stenting, only some dozens perhaps per year. You would probably know better.
As Petra said, we're doing about 230 to 250 a year, and we cover 1.2 million. And so if you sum that up to whole Finland, we should be somewhere around about 1,000 endarterectomies a year. I'm not exactly sure about the figure, but quite a small percentage is done for asymptomatic. It's under 20% in our clinic, and the stenting is done only on special indications. That is, for example, after radiation, hostile neck, or some situations of restenosis, or some special situations where of very high operative risk. So those are done very, very, very seldom.